Good afternoon. My name is Dr. Brandon Ito. I'm an assistant clinical professor of psychiatry at the David Geffen School of Medicine and the director of Justice, Equity, Diversity, and Inclusion at the Tarjan Center at UCLA. I'm excited to be with you all today to discuss the topic of gender diversity in neurodiverse youth. For my disclosures, I have no financial disclosures, and I identify as an adult, neurotypical, cisgender male. For me, it's important to disclose my personal identities in order to acknowledge that my personal biases, perspectives, and privileges may be different from individuals within the gender and neurodiverse communities. This is particularly important whenever we discuss any data on marginalized or underserved communities from which we don't belong. My hope and goal for this talk is to share information as well as my personal clinical experience with each of you in order to assist in increasing knowledge to better serve gender diverse youth with ASD and their families. The learning goals for this afternoon will be to describe literature on the overlap between diagnoses of autism spectrum disorder and gender dysphoria, to introduce some hypotheses to help understand the co-occurring phenomenology, to review some controversies and limitations of the current literature, and also to provide some recommendations when working with trans and gender diverse youth with ASD. To start, some of you may be asking, why is this topic important at all? Well, over the past several years, there has been an increasing awareness among the general public as well as within the gender diverse communities about the increased incidence of autism spectrum disorder within the population. One of the reasons why it's so important to understand this literature is that as overall awareness increases in the general population, you as clinicians are increasingly likely to encounter individuals with ASD, both questioning their gender identity or conversely, interact with an increasing amount of trans and gender diverse individuals presenting for diagnostic testing for ASD. When we look at surveys of transgender and gender diverse individuals with autism spectrum disorder, 1/3 report that they had their gender identity questioned at some point because of their ASD diagnosis, demonstrating ongoing barriers for gender diverse youth with ASD in obtaining appropriate medical care. We know that trans and gender diverse individuals face a significant amount of negative experiences in healthcare, which results in delays in treatment, avoidance of preventative care, and increased risk of negative health outcomes. Finally, it's important to acknowledge and recognize that a large number of trans and gender diverse individuals are currently under and experiencing high levels of stress related to the hundreds of anti-trans and anti-LGBTQ legislation currently being considered and enacted across the country. As showing in this graph, in 2001, more than 250 anti-LGBTQ bills were introduced into state legislators, with 33 states introducing more than 100 bills specifically aimed at curbing the rights of trans individuals. Legislation included bills restricting use of bathrooms, playing on team sports, as well as bills banning physicians from providing gender-affirming care to trans and non-binary individuals, youth. It is our duty as professionals and clinicians to both reduce any potential harms experienced by gender diverse and neurodiverse individuals within the healthcare system, as well as mitigate the increased mental health stress created by laws and discrimination. Before diving into the data, let's start by defining a few key terms and concepts. So one way to visualize the components of gender identity is to imagine overlapping spheres of sex, so the biological indicators of males and females, gender roles, these are the socially created roles of how males and females should behave, as well as gender expression, which is the outward or publicly lived role as male, female, or other. In the overlap of these is where we are discussing gender identity, which is an individual's internal sense as being male, female, or other gender identity. A related concept is sexual orientation, which includes an individual's sexual attractions, behaviors, and relationships, which may overlap with gender identity or be completely separate. So to review, I'll give everybody a brief second to review the DSM-5 criteria for gender dysphoria in children, which requires 6 of 8 symptoms for at least 6 months and must include criterion A1, which is denoted with an asterisk. What I want to highlight for the group is how many of the criteria for gender dysphoria are premised on a presumption that there are certain social rules and behaviors that girls and boys naturally prefer, whether that be certain clothing, toys, games, and playmates of their assigned gender, which influences the diagnostic criteria. For adolescents and adults, the diagnosis of gender dysphoria requires 2 of 6 criteria for at least 6 months. And while it includes much more language about discontent with physical sex characteristics, still contains language around behaviors of quote unquote the other gender or gender roles. In reviewing the diagnostic criteria, we can start to begin to think about how these criteria may interact or present differently, potentially, in youth with the current co-occurring diagnosis of ASD. So to give you a couple of examples, so how do individuals with challenges in understanding relationships and social reciprocity learn these social cues or roles around gender and gender roles? How does hyperreactivity or hyporeactivity to sensory stimuli impact body dysmorphia frequently seen in trans and gender diverse individuals? So let's move on to look at some of the current data. In general prevalence and general estimates of prevalence of gender dysphoria, it has been estimated that 1 out of every 10,000 to 50,000 individuals meets criteria for gender dysphoria. If we take a general estimate of the number of individuals who meet criteria with autism spectrum disorder, it's approximately 1 and 2% of the population, we would expect that the overlap or the intersection between these 2 diagnoses to be extremely rare based on the numbers. However, we see from many studies that in gender-referred youth, so individuals with gender dysphoria who are in gender clinics, we see that the diagnosis of autism spectrum disorder ranges from about 6 to 12% of the youth in the clinics. Data has shown that children with ASD are 7.6 times more likely to wish they're of the opposite sex. And also individuals with ASD report a higher number of gender dysphoria traits, even with or without a transgender identity. When we look at in assessing for gender dysphoria, 2 of the most common questionnaires utilized in both clinical practice and research are the Gender Dysphoria Questionnaire for Adults and Adolescents, so the GIDQYAA, and the Utrecht Gender Dysphoria Scale, both of which have been shown to have high sensitivity and specificity for the diagnosis of gender dysphoria. Just to give a couple of examples of elements of or questions in each of the surveys. So in the GIDQY, an example would be, in the past 12 months, have you felt uncertain about your gender? That is, feeling somewhere between a man and a woman. An example of a question on the UGDS would be, I feel unhappy because I have to behave like a boy or girl. Or every time someone treats me like a boy or girl, I feel hurt. These are rated on a 5-point Likert scale. One of the earlier studies that came out around 2010 in a very well-known gender clinic in Amsterdam started to look at what clinicians perceived as a higher incidence of children and adolescents with the diagnosis of ASD being seen in their specialized gender clinic. In this study, they looked at 204 children and adolescents in the clinic, and through a diagnostic interview, assessed for gender identity disorder. So this is the prior diagnosis, which was coded under the DSM-4, or gender identity disorder not otherwise specified, and assessed for an autism spectrum disorder diagnosis using the DISCO-10. The children and adolescents were assessed in clinic. Their gender identity was assessed in clinic at 0.0 and also 1 year apart. And what they found is the children 7 to 10 years old with gender identity disorder met criteria for ASD. About 6.4% of the kids with gender identity disorder also met criteria for autism spectrum disorder. When they looked at the kids who met criteria for gender identity disorder not otherwise specified, 13% of those kids also met criteria for ASD. Looking at the children and adolescents 12 to 18 years old, of those with gender identity disorder, 6.5% met criteria for autism spectrum disorder or were diagnosed with autism spectrum disorder, and 37.5% of those with gender identity disorder not otherwise specified also met cutoff criteria for ASD. Combined, this led to a overlap or a incidence of 7.8%, which again is much higher than we would anticipate given the low prevalence of each of the two diagnoses of gender dysphoria and autism spectrum disorder. One of the most interesting pieces of data that came out from this article is that when they looked at the adolescents 12 to 18 years old, while the younger children, 7 to 10, did not necessarily persist with the diagnosis of gender identity disorder, the 12 to 18-year-old groups, approximately 80% of those who identified as trans or non-binary persisted in their gender identity 1 year later. Additional studies that have looked at the co-occurrence between gender dysphoria and autism spectrum disorder have looked at the prevalence or incidence in many different ways. So some studies in individuals with a pre-existing diagnosis of gender dysphoria, the percentage of individuals who also met criteria for ASD is estimated to be around 5 to 50%, 54% based on the research. So based on using the autism quotient, the SRS or the ASDS, it changed the cutoff or the threshold for individuals who met criteria for both diagnoses. In looking at populations with a pre-existing diagnosis of autism spectrum disorder, research has found that 0.5 to 4% of individuals in this population also met criteria for gender dysphoria. In a recent study from Simon Baron-Cohen's group, looking at 641,000 individuals using data from 5 large databases, they found that transgender and gender diverse individuals were 3 to 6 times more likely to have a diagnosis of autism spectrum disorder versus their cisgender counterparts, once controlling both for age and educational attainment. So if you look on the graph on the right, the odds ratio is on the y-axis, the different databases are on the x-axis, and what we see is that individuals who identify as trans or gender diverse had much higher odds ratios of being diagnosed with autism compared to their cisgender counterparts. And similarly, when we look at research on self-reported gender identity, it's been shown that both sex-assigned males and females with diagnoses of ASD are just much more likely to identify with a non-cisgender identity. So for example, if you look at this chart, so males with the diagnosis of ASD are just less likely to identify as male, as well as females with the diagnosis of ASD also identify with just a much broader gender identity variance. And while we're primarily focusing today on gender identity, individuals who have diagnoses of ASD are also more likely to identify with a non-heterosexual sexual orientation. So again, the top area showing males with the diagnosis of ASD just having a more varied sexual orientation, as well as females diagnosed with autism spectrum disorder. There have been several ideas or several theories put out there to try to understand why would there be a higher incidence of trans or gender diverse identities among neurodiverse youth. One of the theories that has been posited is related to this extreme male brain hypothesis developed by Simon Baron-Cohen, which posits that ASD traits are part of a masculinized female phenotype. So with this idea is that pre or antenatal exposure to sex hormones may increase the risk for both ASD and also may influence an individual's gender identity. Some of the supporting pieces of data include that autism quotient scores are significantly higher in trans men, so natal females or females assigned at birth, compared to trans women. Also, when they look at different brain types of individuals, they found that significantly higher percentage of individuals were categorized as type S or extreme type S brain types among transgender individuals. So these brain types are high on organizing skills and lower on empathizing skills. Other perinatal factors that have come out in the research, so higher birth weights have been associated with gender nonconformity and ASD traits. Increased ASD traits were seen with advanced paternal age and high sex sibling ratio, which is also seen more often in individuals with gender diversity. And there's also some idea of genetic influences. So there's both a correlation between ASD and gender dysphoria, a higher correlation among twin sibling pairs. And also associations have been found between gender dysphoria and genes involved in sex hormone signaling. Again, going back to this idea of perhaps different perinatal exposures to sex hormones. Other data has pointed to the fact that transgender individuals have higher comorbidities with psychiatric disorders. Of course, this is related to the minority stressors that people face, but again, may point to some underlying genetic link or vulnerability. Cognitive theories have posited that children with profound cognitive deficits and autism spectrum disorder just may have more difficulty articulating a consistent gender identity. Or additionally, children with ASD may speak with less depth about their self-concept or have less depth and nuanced concepts of gender. So examples would be, what makes somebody a boy? What makes somebody a girl? Other cognitive theories have included cognitive rigidity and intolerance with ambiguity. So perhaps individuals who meet criteria for autism spectrum disorder may be fixated on gender existing either on a dichotomy of maleness or femaleness. So if I'm not identifying with all factors of maleness, perhaps that means my identity is transgender or non-binary. Or sometimes people may conflate issues of gender identity with sexual orientation. So I am a male, I am attracted to males, therefore I must be a girl or a female. Social theories to explain the potentially higher overlap between the diagnoses. It posits that gender, the meaning and expression of gender is learned, often from peer feedback. And so individuals with autism spectrum disorder may have less contact or maybe less responsive or maybe less influenced by peer or social feedback regarding strict gender rules within society. It also posits that deficits in theory of mind can impact gender development. So for example, if individuals have a diagnosis of autism spectrum disorder and or gender dysphoria and have a history of bullying or a lot of peer rejection, this can impact their social development and lead to crossover traits. Another idea is that having a gender or sexual minority identity may help some kids with ASD develop or provide a community and explain feelings of being different from others. So perhaps instead of autism spectrum disorder symptoms causing difference from peers, perhaps it's just because our gender identity is different. Several of the major criticisms of the data of gender dysphoria and autism spectrum disorder point to the fact that several of these studies rely on either single item questions from the CBCL, which is, I wish to be of the opposite sex, either never, sometimes, or often, or rely on parent reports in order to make the diagnosis of gender dysphoria. The other criticisms include the majority of studies, patients were collected from gender clinics. And in general, clinically presenting populations are overly represented with diagnoses of autism spectrum disorders. An example or a co-example would be that gender dysphoria is similarly elevated amongst clinically presenting ADHD children. Other criticisms include that the biological and social theories both don't explain gender dysphoria in natal males and also don't account for psychosocial stresses of discrimination, prejudice, violence, internalized transphobia that also can lead to psychiatric comorbidity. Lastly, one of the important criticisms is that with the diagnosis of gender dysphoria is it's pathologizing gender diversity. So if we think about it in relation to the diagnosis of homosexuality, which used to be in the DSM, gender dysphoria is not an inherent psychiatric illness, but really the dysphoria is a result of the minority stress and social stressors we discussed. One of the things that I want to put out is just some of the diagnostic and treatment challenges when working with populations who meet criteria for gender dysphoria and ASD. So one is that for kids, even without a diagnosis of autism, understanding gender variance, ambiguity, and expression and rules around gender is really difficult. There's also significant heterogeneity between individual presentations of both gender identities and of symptoms of autism. And also there's a huge lack of knowledge in both providers and services to be able to provide the treatment needed for transgender youth and individuals with autism. Other diagnostic challenges can be difficulty differentiating core symptoms of ASD and core symptom and co-occurring diagnoses. So an example would be, is a restricted interest in gender or feminine clothing, is that a restricted interest or is that a cross-gender identity? Is a worry about being transgender a part of a cross-gender identity, or is it related to OCD symptoms? Lastly, one of the things to consider in treatment, so gender affirming treatment, is that the impact of core ASD symptoms, which may affect both somebody's tolerance to hormone treatment or individual injections, or for example, say somebody has a sensory sensitivity to body hair and they identify as a trans male. And on hormone therapy, they start to develop body hair. This is going to impact perhaps how they feel in their body because of their related sensory issues. All right, lastly, I want to put out a few recommendations or considerations in supporting our trans youth with ASD by first pointing out that healthy gender identity formation is really important. It impacts socialization, sexual functioning, it impacts peer relationships. We know that early intervention to treat gender dysphoria reduces risk of psychiatric conditions such as anxiety, depression, trauma, and later physical health problems. Gender affirming treatment has shown to increase satisfaction in lifestyle, overall well-being. It's also shown to reduce suicidal ideation and behavior and also improve psychiatric conditions and gender dysphoria. So when working with individuals with ASD, it's important that we take a thorough developmental history and include questions on gender identity and sexual orientation. How do you identify your gender identity? How do you identify your sexual orientations? Are you attracted to individuals of the same, opposite gender, or other gender? It's important to identify areas of urgency and distress related to their gender identity. So if somebody has a significant amount of body dysphoria, the time around puberty might be especially distressing to them. When working with individuals with gender dysphoria, it's important to always screen for ASD as well as any psychosocial or developmental challenges, given the increased incidence of autism spectrum disorder. It's also important to screen for psychiatric comorbidities that may come along with autism. So tic disorders, learning disorders, ADHD, schizophrenia, which individuals may not specifically think about when just working with trans youth. Also, it's important to identify the family and community supports because they are going to be key in both treatment of the dysphoria and also gender affirming treatment. Some treatment considerations on working with youth with both ASD and gender dysphoria is to provide a spectrum of gender identities. So we talked about the potential cognitive rigidity. Sometimes it's useful to present youth with different ways of expressing themselves, different gender expressions, different ways of using preferred names or using different pronouns to see if it matches their gender identity. Psychoeducation and family support is also very important or crucial. So some families may have recently gotten the diagnosis of autism spectrum disorder, and now they're also trying to understand their children's needs in relation to their gender identity. For individuals with ASD, it's important to elicit the goals and also the expectations for the future. For a lot of trans youth, by the time that they come out to providers or come out to families, it's something that they've been thinking about or known for many, many, many years. So it's important to understand what are our hopes and goals for treatment. Again, encouraging gender expression and exploration. And also to put out there, it's important to refer for expert medical evaluation, particularly in gender dysphoric youth who are prepubertal. One of the reasons is medically, if they are prepubertal, they may qualify for puberty blockers to delay the onset of puberty, whereas once the secondary sex characteristics have set in, it's much more difficult to treat. From a justice, equity, diversity, and inclusion lens, it's important to point out that in the data we have, there's still a significant lack of data inclusive of race and ethnicity. This not only includes the estimates of prevalence, but also the validity of the diagnostic and screening tools that we use within diverse or minority populations. One of the concerns is that there may exist additional disparities in illness, healthcare access, provider knowledge and support, family and community support, and satisfaction with healthcare for racial minority groups. Again, one of the issues related to diagnosis is the risk of pathologizing or medicalizing general difference and diversity. So trans and non-binary identities have and do exist within several cultures around the world and are often the most revered individuals within communities. That is different within our social structure, but just to say that in many different communities, a broader gender identity is something that is seen as very positive. And again, there's lack of data both about the risk and resilience factors of intersectional identity. So if somebody has autism, a diagnosis of autism, identifies as transgender, and is also a racial minority individual, we don't have a lot of information about what are the specific risk factors for this individual, and also what are the areas of resilience. I wanted to end by leaving you with a few words based on a blog that I read. So the author is Lydia Brown, who I believe identifies as genderqueer. Just to get a sense from their perspective of how they experience both their diagnosis of autism and also their gender identity. So in quote, "Being autistic doesn't cause my gender identity, but it is inextricably related to how I understand and experience gender. For many, but certainly not all autistic people, we can't make heads or tails of either the widespread assumption that everyone fits neatly into categories of men and women, or the nonsensical characteristics expected or assumed of womanhood and manhood. We deserve movements that recognize and affirm experiences that cannot be easily separated into trans or autistic issues only, especially given the commonalities of the oppression we face. It's okay to be autistic and trans, and it's okay for those things to be related and overlap. So in summary, individuals with autism spectrum disorder may be more likely to identify with gender identities and sexual orientations outside of the ordinary binary. Transgender youth with ASD may face additional difficulties in expressing and exploring their gender identity related to core symptoms of autism. It's important to refer and collaborate with gender clinics and clinicians with expertise in gender dysphoria early in treatment if it is something that comes up during treatment, and to emphasize that we're only at the beginning of understanding this broader narrative of a multitude of different diverse perspectives and identities. So I will stop there, and I appreciate and thank all of you for your attention.